Welcome to Mended Hearts at Home. A large portion of this educational video was recorded during the Chapter 94 virtual support meeting held on May 17th of 2020. My name is Jeffrey Steinhorn, and I am the accredited Mended Hearts visitor who worked in the background as the Zoom meeting host during that event. Solicited questions were collected and submitted to Dr. Taylor before his speaking. These were consolidated and answered after his introductory remarks. Questions submitted during his talk used the Zoom chat feature and were repeated to Dr. Taylor by me for his response. As Mended Hearts does not provide medical advice, you should always ask your doctor or other health provider regarding specific concerns. Norm Linsky, the Chapter 94 secretary, will now introduce Dr. Taylor.
It's a pleasure to introduce our presenter, cardiologist Dr. Alan Taylor. Dr. Taylor wears many hats: Chief of Cardiology at Medstar Georgetown University Hospital, Medstar Washington Hospital Center, and Medstar Heart and Vascular Institute. One of the main hats Dr. Taylor wears is that of strong supporter of our Mended Hearts chapter here in the nation's capital. He knows how important our peer-to-peer support is to recovery from heart disease and living life to the fullest. With the onset of COVID-19, Medstar has been adapting quickly, and Dr. Taylor has played a key role in that response. As Medstar's Director of Heart Care throughout our region, he has led efforts to redirect hundreds of cardiologists, cardiac surgeons, and their teams to COVID-19 care. We correctly applaud these professionals as heroes, but every single one of them simply says, "I'm just doing my job." Thanks, Dr. Taylor, for leading that great team. You all know about the special challenges of treating COVID-19 in persons with heart disease. Dr. Taylor will address those challenges today. This is very much a dialogue today, so thank you to the wonderful volunteer team that prepared this program, and thank you all for being here today. Dr. Taylor, the floor is yours, sir.
Thank you, Norm. Hi, everybody. So my name's Alan Taylor, and as Norm introduced me absolutely perfectly, I'm a cardiologist, and I work for Medstar Health at our Medstar Heart and Vascular Institute. And I want to just thank you, Norm. Thank you, Mended Hearts. Thank all the listeners, and really thank you for letting me do this with you today. I hope everyone's staying safe and staying well. And I'll echo Norm's comments that this really does take a village, and I'm super proud of our team. They've been performing really well over the last 11 weeks that we've been in our COVID response. Yes, 11 weeks, and continue to do well. And I'll explain to you today a little bit about what COVID is doing within the heart care spectrum, talk a little bit about COVID in general, COVID and heart disease in specific, give you some information on where we are with some of the optimistic things like treatments, but then just information on how to protect yourself and how to stay engaged with the healthcare community, with your healthcare providers. We've learned quite a bit over the past 10 weeks. I think I've got some good tips and advice for you that could be helpful. So, and I've received all your questions, and I've incorporated 100% of them into my comments here. But I'd love to take more that you may think of as we go, or you didn't submit in advance, and so just go ahead and submit those to the chat function. So COVID-19, and COVID-19 stands for Coronavirus Disease 2019. That was the year in which it began. Is a respiratory virus caused by the virus known as SARS-CoV-2. In other words, that stands for Severe Acute Respiratory Syndrome Coronavirus 2. So there are many coronaviruses. They are very small, simple viruses that cause infections, some in animals, some in man. And this is not the first episode in man of having a SARS, a severe acute respiratory syndrome outbreak involving coronavirus. And so we've seen this before. But this is clearly the worst pandemic in the last century. And it is here, it's come with a vengeance. Everything you've heard on the news is true, and I'm going to go through a lot of it. And, we're really both happy for the support of the community and helping us keep everybody safe and deliver the care needed, but really want to be mindful of where we're heading right now as a community to kind of not prevent this from getting worse, because I don't think we're out of this quite yet. So viruses are very small, simple particles, and they are basic, and a virus can't do anything inside of you without relying upon machinery inside of cells. You have thousands and thousands and thousands of genes in your body to make you a human being. These viruses have 15. They are very simple little things, but they are foreign to us. And when they get inside of us and they use our own body's machinery to divide and replicate and to increase in numbers, it's foreign. And so then it triggers a very intense inflammatory reaction that, I'm just getting a call here. Let me just decline. It varies. It triggers a very intense reaction to that viral replication. So the virus actually enters through your respiratory tract. It could, or basically your eyes. You could inhale it through your nose. You could inhale it through your mouth. But it's got to get inside of you. It does not come through your skin. It doesn't come through simply touching something, unless you touch something and then touch your mouth or your nose or your eyes, and then it can have an entry into the body. Once in the body, it won't do anything unless it can get actually inside of a cell, because the virus has to get inside your body cells for it to use the machinery of those cells to increase in numbers. And this virus does so through a very specific way. It goes through a receptor think of it as a docking station that's on the cell surface or the outside of the cell. And it connects to these very specific receptors that we hear a lot about in heart disease. It's called the ACE2 receptor, ACE2. And it's a receptor that acts in the system that is very important in determining how blood vessels function and our immune system, our inflammatory system. And those receptors, those little receptors that are docking stations for the virus, are very concentrated in the respiratory system. And so this virus comes into the respiratory system and uses a receptor on your cells, not intended for this function, to basically enter the cell and then goes haywire. It is again transmitted on a respiratory basis, but the particles can live on surfaces. The viral particles can live on surfaces, and there's been research published this in the New England Journal back in March that explored and experimented with SARS-CoV-2 and put it on different surfaces and just saw how long it could survive. It can survive up to about 3 days on very hard surfaces like steel. On soft surfaces and porous surfaces like textiles or paper, the duration of survival of the virus is much shorter, on the order of a day. But yes, your newspaper, if touched by someone, could have SARS-CoV-2 on it. It is paper, and the virus can live for 24 hours on paper. And yes, that handrail in the stairwell, if it's steel, could have had virus on it 3 days ago and still be there. And then by touching that, again, then you touch your face and it can get inside your body. Once inside the body, it takes a few days for the virus to start to ramp up and start to use the body's machinery to increase in numbers. And the onset from the time a virus comes into, as a person, a human, you start to feel symptoms from that is about 5 days on typical. It can be a little shorter, it can be a little longer, and it can be up to about 14 days, which is why you see the signs around the Beltway saying, people from New York and New Jersey must quarantine for 14 days. Where'd 14 days come from? It's based on the fact that if you've been exposed, it could be up to 14 days before you start to show symptoms of being infected. And those symptoms are predominantly symptoms in the respiratory tract, so breathlessness and cough, and then fevers, and then some general viral symptoms, body aches and the like that you're familiar with from the flu. There's a specific interesting symptom that comes from with coronavirus, and it's that of not being able to smell or taste. It's because it's felt that the virus actually interferes by going into those specific cells, which are very few in number but very important to smell and taste, and impairs those cells. And so you can no longer, it's called anosmia, the inability to smell. So loss of taste and smell is a symptom of coronavirus. There are really two phases to the disease that we're seeing. There's there's three phases actually. There's an early asymptomatic phase. The virus is replicating, but symptoms haven't started. Then there's a respiratory phase when the predominant symptoms are breathlessness and cough. And then there's a severe and late phase that some people experience, which is an inflammatory phase, where the body's own inflammatory machinery gets so ramped up fighting the virus that that inflammatory response starts to harm the body as almost like an innocent bystander, and then wreaks havoc on organ systems throughout the body. So it's these three phases that this exists in. And one of the things that's been very challenging in the healthcare community to deal with this is that we see everything from asymptomatic infection, meaning people have had coronavirus and don't even know it, to people that have very mild symptoms, and people all the way up to including, as you've heard, fulminant, severe, overwhelming, and fatal infection. And it's that spectrum from asymptomatic all the way through just becoming the sickest of the sick you could imagine, that really, really challenges us as a healthcare community. It's more infectious than the flu. It's more deadly than the flu. We still don't know exactly how much, because precise numbers on how many people have been infected and how many people have been needed to be hospitalized of those, and how many have died. But the case fatality rate appears well below 1.5% now, which is still from a acute infectious problem in 2020 high. But for folks in the hospital, the mortality rate is anywhere up to 3 to 6%. And the idea is that there's no age, no one is safe from this. No, young and the old can get it. It is, although outcomes are very age dependent, as I'll share with you. We've learned a lot to detect this. You can do very specific tests, and the tests you read about or hear about are the ones that, like a nasal swab is done, and on basically taking liquid or mucus from the nasal cavities, and the virus is in that liquid. That then is put into, so actually sampling, getting the virus itself. That then's put into a testing tube in which it's run through a variety of very sophisticated chemical reactions that amplify or grow the signal of the virus so it can be detected. As small as one viral particle in that sample can be detected in a test. But those tests are very sophisticated, and they've had to be developed specifically for COVID. And that's why testing has been slow to develop and slow to ramp up, because they're complicated tests. The tests you're reading about these days are ones that detect the virus. They don't detect the body's response to the virus, so-called antibodies, that you develop after you've been infected. So while infected, we really need to detect if people have the virus. It's after that we can detect if people have had an immune response to a virus, and even determine if they were asymptomatic, they were exposed. There is certainly a lot of concern in the heart patient community about the risk of this infection as a respiratory virus. And indeed, you've heard that a variety of things, and I want to kind of cut through and describe really, where is the risk of this? Now, the first thing we know is that if you're an older person, you are at risk, and for getting the infection more likely than not, or more likely to get the infection if exposed, and more likely to have a severe reaction to the infection if you contract it. There are some risk factors for poor outcomes in hospitalized patients, and those include age over 65, and include a history of heart artery disease or coronary artery disease. That could include stents or prior bypass or heart attack. Folks who have a history of heart muscle weakness or heart failure are at particularly increased risk. And those with chronic lung disease, no surprise, this is a lung virus primarily. Those with chronic lung disease suffer. But not to scare you too much, the disease is not uniformly fatal in any group, and even in the old and those with heart disease or heart failure, the risk for a poor outcome might be 2 or 3-fold higher. That is, if a person without heart disease if hospitalized, has a 5% risk of death, it might be 10% in a patient who's had prior heart disease. Now, while double and important, it isn't 100%. And so the infection can be still mild, can be still very survivable, even in folks with prior heart disease. But the older heart patient is a vulnerable patient and deserves to be exercising really important preventive measures to get infected. We also learned, of the drugs that you may take for your heart disease, it appears that there aren't any of them that have any negative impact on your ability to do well with coronavirus. And I'll explain. There's been, in fact, some noise, and maybe you've read about it or heard about it in news reports, that ACE inhibitors, those are drugs like lisinopril, or angiotensin receptor blockers. Those are drugs such as candesartan or losartan. There's lots of these different drugs out there. Those are drugs that act in the ACE system. And remember, when we started, I told you that this virus attacks and enters cells through the ACE2 receptor. It's one of the receptors within that angiotensin system that these drugs like lisinopril or losartan or candesartan act within. But there's no evidence that, in fact, taking those drugs actually has any potential negative effect on your ability to survive or do well with this infection. In fact, to the contrary, there's even some evidence, although I would say it is mixed, that patients who are taking those agents, those drugs like lisinopril, losartan, candesartan, actually may fare a little better if infected. I think the jury's out on that, I would say. These are what we call observational studies. A group of scientists will collect data and observing a population, and then to see what associations or relationships they can find. It doesn't tell us that those drugs are causing that relationship. It's just they are associated with a relationship. So it would take drug trials, or what we call randomized clinical trials, very formal tests of drugs in coronavirus to see if these drugs work. And such trials are actually underway as a way to learn more about around COVID-19. But certainly the message from that is there aren't any of your medicines you're taking right now as a heart patient that you can't take and that you can't take, or that might change or alter your risk, certainly worsening your risk for any problems from the infection. There are specific treatments for coronavirus. I would tell you that most of what we do in the hospital for patients that have significant infections and need to be hospitalized is supportive care. We make sure they're getting adequate levels of oxygen, and their organs are functioning well, and we provide whatever support is needed to have them naturally fight off the infection. When needed, there are some other treatments, though. You've heard about a few of them. You've heard about a drug called remdesivir as a specific antiviral drug. You've heard about taking blood or convalescent serum, that is the liquid that is in the blood, or the liquid of the blood, and taking it from patients that have been infected, and like a blood donation, and then infusing it or giving it to patients who've not been infected. So taking the antibodies that a person who's been infected before has already built up and seeing if those antibodies can then help another person fight off the infection. And then there's another drug called, and it's got a complicated name, it's called tocilizumab, and it's a specific anti-inflammatory drug. And I'll just describe what we know about each of these three drugs, because right now they are the three principal active treatments that we have. Remdesivir is the one that's the furthest along. There's been some studies published. It's a drug that targets the ability of the virus to actually divide and propagate, or not divide, but propagate and grow inside cells, and turns that off. It's a decoy for some of the things that it's a decoy drug for some of the things the virus needs to replicate and increase in numbers. It's an intravenous drug. It's not a pill. And the data on it so far, I would say, are mixed. Now, in a disease, it's very dangerous. Any help any help in fighting it is welcome. But it's not. This drug doesn't look like it's a panacea, meaning it's not a perfect solution. What the data show so far, and it's why the FDA apparently has approved it for use, and now they're distributing the stock that's available in the country, that it shortens the duration to recovery. So if on average, people without the drug got better in 15 days, it took 11 days with the drug. Now, it's 4 days shorter, which is good, but still are sick with this a long time. And that's one thing we're really learning in this COVID treatment era. This is an infection. This is not like the flu. You get it, you feel bad for a couple of days, and you're back at it. This infection, when severe, lasts for weeks and weeks. And it's why you're seeing the numbers around the country go up and stay up so long, because it simply doesn't come and go that quickly. And we're certainly seeing that in our own system. But remdesivir is an opportunity, is a treatment. It probably works best early, when given very early in the disease, before the virus has had a chance to replicate or increase in numbers too much. Because remember, that's how it works. It works to reduce the ability of the virus to multiply. And so if you give it too late, there's already so much virus, so you really have to use other treatments. And such a treatment would be what we call convalescent serum. Again, that's that blood donation from a patient that's recovered from coronavirus, where then the liquid is taken out of the blood, and then that's given back to a patient that has coronavirus. So those antibodies of the person who survived the infection can help the person with the infection fight it off. That looks safe thus far. There's some small series of patients published that it looks like it helped them get better through a variety of markers in the blood, in the body, that showed maybe help them fight the infection. But we still don't have trials of comparing convalescent serum to no treatment at all, a placebo, to see exactly how much it helps. But right now, we are actually administering convalescent serum to our patients to help them get over the infection. I mentioned to you there were 3 phases of the disease. There was the asymptomatic phase, the respiratory phase, when shortness of breath, and really the lungs can be really severely attacked. And then there's an inflammatory phase, when the body's own immune system just gets so revved up, it just attacks the body as an innocent bystander. And that's this inflammatory phase where the third treatment exists, this drug with a complicated name, tocilizumab. It's a drug that basically knocks down your immune system by knocking down some of these mediators of the immune system that then turn to be hurting the body. And that actually looks fairly successful when people are in this advanced stage of this really over-immune condition. It's, again, an IV drug. It's very sophisticated. It's administered once. And we are also administering that in patients who are in this hyperinflammatory phase of COVID. Not all go into that hyperinflammatory phase. Again, many people get over this as a mild infection. Some get a respiratory phase, and that's it. And for some reason, some go on to have this really intense immune phase. And those are the patients that you're hearing about that are being put on things like total body life support and that sort of thing, to give them some time to support their body while they fight off the infection. What we don't know yet is exactly how effective all three of those therapies are and what combinations they should be used in and under what triggers, how early in the disease and whatnot. It's just a lot to learn in 2 months, how to treat a complex new disease, and with all the nuances we need to learn. Someone also asked, are there other things that happen with coronavirus? And the people have heard about clotting, and indeed clotting is important in heart disease because clots are what cause heart attacks and strokes, for example. And indeed, coronavirus does cause some clotting. Just like the immune system gets all revved up, the clotting system does too, and that can cause some problems. So, and it looks like clotting rates in hospitalized patients are higher than typical. And so we are treating patients with anti-clotting treatments when they're in these particularly inflamed, this inflammatory phase of the illness. I mentioned to you that the recovery is slow, and it indeed is. We've had even healthcare workers that have, we've had many of our healthcare team get infected. We have about 30,000 employees. About 500 have become infected. And so about 1 in 60, about 1.5% of our workforce has become infected while taking care of patients with coronavirus. Now that number is high, but I'll tell you that PPE, the personal protective equipment, works. So we've been doing all we can to protect our teams from getting infected. But even with that protection, some have contracted the virus either at work, and I guess there's a chance they could have contracted it outside of the workplace. But they are, being a healthcare worker definitely has posed a risk in this situation. The recovery, though, for these patients is quite slow. It takes weeks. It does not occur quickly. And it's one of the reasons this infection is so hard on the healthcare system, because once a patient gets very sick from this, they're in the hospital for weeks. And again, that really has clogged up the hospitals, as you've seen in systems where there's been, like in New York, where there's been a high burden of infection. And the last thing is, well, if you get over it, is that it? Are you good to go? Or are there long-lasting effects of this infection? And I guess we don't really know quite yet. We haven't observed that part of this story yet. I can say that certainly from other viruses of the SARS type, there can be long-lasting effects on the lungs or the heart. We're hoping and praying that that's not going to be very frequent, and we don't think it's going to be a massive effect, but there's been so many people affected by this virus. We're going to see patients that are coming back into the hospital in months and years with heart muscle weakness, from heart muscle inflammation, for example, a condition called myocarditis, that might be a long-term effect. Really, the heart effects of this virus right now are acute myocarditis. We are seeing some heart attacks triggered by it. About 40% of the heart attacks we're seeing right now are coronavirus heart attacks. They're not typical heart attacks. They're triggered by the coronavirus. And we're seeing some worsenings of heart failure as the three main things. Key thing with this, if you're a heart patient, and any person for that matter, is to protect yourself. Again, you don't get this infection if you aren't exposed to it. And so avoiding exposure is the key thing. And that's why you've heard so much about social distancing, avoiding crowds, because you don't know who's got it and who doesn't. You can be asymptomatic for days and days and days and have it. And you can have it and never have a symptom and yet be spreading it. In fact, we're starting to screen patients that are coming in for procedures. Before the procedure, we'll have them get a COVID test just to make sure before they have anesthesia that we know if they're infected or not. About 2.5% of those people are actually show us infection, show us they're positive when we test for the virus. So there's a lot of asymptomatic infection out there, or low-level symptoms people aren't even recognizing, which is why it's so important if you're going to the grocery store or wherever that you protect yourself with a mask at all times. Again, it has to gain entry into your respiratory tract. We don't have people wear eye protection, but in the hospital we certainly do. And so not being around people for long periods of time so you don't have potential for eye-related infection. Hand washing is critical, because if you touch things, again, it could be up to 3 days. The virus is on those surfaces. So if you wash your hands with soap and water or an alcohol-based wash. That should take care of it. And then, of course, it's about just making sure you're as strong as possible to have your own immunity take care of the infection. And one question we received is, are there ways that you can boost your immunity? Are certain vitamins, alone or in combinations, helpful? I would say that overall immune competence or immune strength is a complicated topic, and there's not much that really helps other than nutrition, proper rest, so avoiding fatigue, exercise and fitness. And on vitamins, unfortunately, I can't recommend to you a vitamin supplement like a vitamin C or a multivitamin that would be helpful. It'd be wonderful if there was, and I would, if something comes up around that vitamin C helps, it would be wonderful, but we don't have any information of that nature right now. So it's really general physical conditioning. The stronger you are, the better off you are. And so good nutrition, good rest, and staying physically fit. One thing we're definitely seeing through this infection is that, and it's an untold, there is an untold burden of this coronavirus era, which is that many folks with all sorts of diseases, heart disease among them, are avoiding coming to seek attention for their problems. I would have predicted that when this started, we would have seen a rash, an influx of patients with heart attacks and heart failure, much greater than we normally see. In fact, it's been the opposite. We've either seen the same or less patients with active heart attacks or new heart attacks, or coming in newly with heart failure as a problem. There's complicated reasons for this, and this has been observed across the world, even in other healthcare systems. Part of it is that, and it's complicated, I think some of it is just like you don't want to go to the movie theater right now. Folks want to stay away from the hospital because they're fearful that it's a place where there's concentrated illness. They are isolated and not having the support of family members to observe them or to ask, should I go to the hospital? I'm having chest pains. I'm not breathing well. What should I do? I think folks also worry that they're going to burden the system. The system's busy and they're taking this response, and they don't want to use healthcare resources that they think others may need. There's many altruistic patients that think that way. Access is a problem. Normal access points where people go, emergency departments or their primary care doctors, aren't open right now or don't have the same type of access. And lastly, it even comes into finance and people's personal finances. People have lost their jobs, or their finances are insecure, or they have health plans with high deductibles and they're worried about that in the setting of uncertain finances. And we think that's played into it. But whatever the case may be, whatever the cause, we are definitely seeing folks are deferring care for important or really critical diagnoses and problems. And we think that's something which, while we'll never know how much of it had happened and what it cost, we know it's out there. And so we want to send a message that we are open, the healthcare system's open. And I'll give you a few examples of that. In the last 2 months, actually now 10 weeks, we've done 11 heart transplants. Normally we'll do 15 or 18 in a year. And so in the last 10 weeks, we've done 11 and have implanted over 20 artificial hearts in the last 10 weeks. And normally we'll do about 80 in a year. So in a typical year, about 100 combined of heart transplants and artificial hearts. And we've, in 2 months, two plus months, we've already done over 30. So a much higher rate than typical, simply because, again, the healthcare system's continuing to help patients get the care they need, and keeping people safe while in the hospital, with temperature screening, masking, isolation, and so forth, really carrying on both missions simultaneously. The last questions we had were returned to, okay, well, so what about follow-up? How do I get my care right now? What do I do to keep myself not just healthy through things I'm doing in my lifestyle, but when I really do have a problem or I do need to seek care, how do I do that? And I say one of the things, just like this Zoom call shows, that we've really just altered the way we work is through the onset of telehealth. Now, telehealth wasn't new. We were picking around it for years. It was growing really slowly because, you know, it was an alternative, but not what was felt to be a less satisfactory alternative than in-person visits. In-person visits are the norm. And in fact, there were a lot of regulations which were just keeping this from taking off. The government, for example, wouldn't pay for telehealth visits. Well, that's a barrier. Provide insurance companies often wouldn't pay for it, or they would pay for it for patients that needed to seek follow-up visits, but not initial visits for healthcare. And also there were state restrictions. You couldn't talk to a person on telehealth that lived in a different, that was physically present in a different state than you were. Well, that's a problem, particularly in the DMV, where we have Virginia, Maryland, the district, Delaware, and Pennsylvania, all West Virginia, all places we get patients from, all of which you can get to in an hour or two. And so we've got all these states around us in a concentrated area, and it really is tough when state lines are a barrier. Well, when the coronavirus situation started, all those restrictions were lifted, and voila, we've gone from doing, as a system in Medstar, under 20 healthcare on a typical day. Back in January, let's say, we would do fewer than 20 telehealth visits a day. We are currently doing over 4,000 a day. We've gone from, you know, little to a huge number, just because both the push of coronavirus and the lifting of the restrictions. I do telehealth visits myself. I think they're really quite good. You can do them on the video, or you do them on phone. I think video is much better. It's nice to see somebody's face. It's nice it's a human interaction, even though we're not together. You know, facial expressions say a lot, and you know, seeing each other is better than not seeing each other. All specialties are doing these now, and you know, we're now doing about basically what our daily typical volume would have been for in-person visits on telehealth. I think the pros of these are some things like it's very good because all the time's for conversation, right? We're in a 20 or 30 minute visit where we talk. These visits, there's lots of talk and listening, and it's a really good way to talk and listen. You really have to focus on it's a one-on-one conversation, as if you know, because there's no phone ringing, and there's no one knocking on the door, and there's no pager going off, and you know, it is together, and a good interaction together. I think they're quite easy to schedule. There's a lot of flexibility because it's of the way they're done, and certainly no contact and no travel. It reduces, I think, the burden on the patient to have to move and park and all that stuff. And I find that they're really a good opportunity to talk about education and review diagnoses, really dive into how people are feeling, ask good questions. There's this mantra in medicine that a patient's history, what they tell you, is your absolutely best test. And I do believe that, which is why I think if I was going to not get rid of one thing, it would be the ability to talk to someone and get information as to what's happening. It's a great chance to review medications. That's another pro, because you can actually have somebody show you their bottles or their list. And it's a great opportunity to involve others, because on a video call, we could have multiple people involved, either in the same location or even different locations. So just like in this Zoom call, we can have lots of people involved. There are some cons, there are some limits, some things you can't really physically examine a patient. We can do some simple things, looking at skin tone or neck veins, or leg swelling. But by and large, there's not much you can do. There's not as much you can do in terms of an exam. And certainly we can't do blood work or testing at the same time. Many of you, when you go to your visits, you probably get a EKG or an echocardiogram or some blood work. And obviously we're missing that right now. And then lastly, I think these are probably better for interacting with the doctor you already know versus when you're meeting for the first time. But I've done both, and I think the pros and the cons are present for new patients and follow-up visits. And in many respects, because connecting and speaking about health conditions is so important, these work pretty well. Then I just have a few tips. If you haven't done a telehealth visit, I want to tell you that I think it's a really good alternative right now. we're going to get quickly back to doing in-person visits. It's going to start though with just for new patients, and we're going to stay probably in the telehealth visits for patients we already know that seem to be doing relatively okay for the foreseeable future. So a few tips if you have a telehealth visit. The first is, have a good device and one with a good connection to the internet, and you certainly be in a quiet environment to avoid some distractions so you can really take advantage of the time. Have your questions written out in advance, and when you get on the line, set an agenda. Here's what's important to me today. I'd like to make sure we do the following several things so that you get through them all. Check your blood pressure and your heart rate beforehand. If you have a blood pressure cuff, do that, or if you have your blood pressure record, have it available, because that'll save some time. And also it's great information to get over the phone. Take notes. Take notes. There's a list, you're listening, and write things down. And I think it's reasonable to ask for written instructions afterwards. And I typically will send an email to the patient afterwards saying, it was very nice to speak with you. You look great. Your house is beautiful. Your wife is funny. And here's what we talked about. Change this medication, increase that, do more of this, do less of that. Involve a family member, either on the same screen or on a remote screen. We can connect through video visits, a second listener, because I think it's so important in health advocacy. And lastly, certainly have your pill bottles and medicine lists ready to go, because that leads to a good chance to review that. Good news is that these are covered by insurance plans. They're done as regular visits right now. The government's relaxed some of those differences. I think that may change. Who knows what'll happen after the COVID situation dies down, what insurance companies go back to, but these are covered by insurance, and so you shouldn't have any difficulty. But there are some pre-authorization steps that your provider might have to go through. So I hope that's a helpful coverage on televisits. They're a pretty good alternative right now, and making good use of them. So don't be avoiding that, or if you're in need of a visit, go ahead and schedule one. So I've covered a lot, and you've been great listeners, and I really thank the questions, which really formed this information I've shared with you, both on how COVID works, what we're seeing in terms of what type of an illness it is, and what the actual risk to heart patients and the heart manifestations are, what we're doing around treatments right now, where we are, what we've learned so far, what we have left to learn, and then how to keep yourself safe, how to protect yourself, and how important it is you see these news reports of people like, great, the beaches are open, let's hit the beaches. I'm like, not so fast. I think I think that does have risks to it, as you've heard, and I would agree with that mindset, particularly for folks that are at risk for significant complications from COVID, the older person or the one with underlying heart or other health troubles. Important to, I think, still lay back for a while. And lastly, how to stay engaged with your healthcare team during this time, and telehealth is the one thing. But certainly, if you're having an active problem, don't avoid coming in. We do. Every health system goes to extreme lengths to keep patients safe. It's what we do first, quality and safety first, and it applies to protection from COVID as well. So thank you very much to Norm and to Mended Hearts, to all of you for being heart survivors and for being interested in your heart health and in taking your time today to listen. I'd love to answer any questions you have. Thank you.
All right, Dr. Taylor, my name is Jeff Steinhorn. I will give you some questions that have been sent to me by chat. I'll do my best to filter through them like you did with yours. You did an excellent job. iPad 2, Phil, says that his mom is in CCU with a flare-up of her CHF. She may be coming home, and both my wife and I are immunocompromised. What do we have to do to make sure we don't get infected from her? What precautions?
Yeah, so I assume that she's been there with heart failure, but does not have COVID, because I know for sure a patient who in any hospital right now that comes with a respiratory symptom is going to get tested for COVID. And if she's COVID negative, there's really nothing there in the hospital. The likelihood that she contracted in the hospital is quite low, Phil. But I would say that it's going to be difficult to isolate from someone living with you because quarters are so close. The good news is I think the chance of contracting this in the hospital is in fact quite low because we know who does and doesn't have COVID. And then even in the ICU environment, we've converted, for example, all of our ICU rooms to what we call negative pressure rooms. And I don't know if she's in our ICU coronary care unit or not, but all those rooms have negative pressure, meaning the air is blowing outside, from inside to out, to keep virus from floating around the room, units from room to room. But I think it's something definitely to ask providers there as she leaves what they recommend in terms of soft quarantining her when she comes back, just to make sure that for a period of at least the better part of 5 days. Remember, the average time to show symptoms is about 5 days, but the chance she got exposed in the hospital is, I think, quite low. I'm glad you took her to the hospital, didn't delay care for her heart failure. I hope she's well. And I think I would set up a telehealth visit for her in follow-up to the heart failure, to connect back with her provider to make sure she's on the right track. Heart failure is a disorder that commonly can flare up again shortly after hospitalization, leading to readmissions to the hospital, something you'd want to avoid. So a telehealth visit to make sure things are staying on track would be a great idea.
Thank you. Spansosa1, that's a screen name, says that they're on, and I have trouble with this, irbesartan.
Yeah.
And have been experiencing delay with availability at my pharmacy. Aside from worldwide delays with shipments in general, is there an expectation to see a shortage in these types of meds due to COVID?
Right, great question. So irbesartan is one of those angiotensin receptor blockers, or ARB drugs. And that's one of those drugs, like we were talking about, that interacts with the system that the virus enters through. But there's no indication that those drugs are causing worse infections or more common infections. And there's some evidence, again, to the contrary, that they might somehow be protective. We get all sorts of drugs go through shortages. Irbesartan, some of the sartan drugs, these ARB drugs, have gone through some shortages due to some manufacturing problems, but it's always manufactured at the manufacturer level. It's not a problem with the drug itself, it's who's manufacturing it. I haven't heard much about irbesartan shortages lately, and so that would be new to me. If you're having trouble getting the drug, though, I would tell you that there are at least 7 different ARB drugs, all of which act and are very comparable in how they act and how safe they are. If there's any class of drugs that act fairly uniformly in terms of how efficacy and safety, the ARBs are one of them. So if you're really having supply troubles, you might think about a substitution of a drug if you can't get it, because these are essential drugs used for blood pressure, heart failure. They're excellent drugs. They're really among our best drugs we have. So do make sure you stay on it.
Someone from the Fire Tablet says, good afternoon. He's 45 years old with history of 5 heart attacks, quadruple bypass in 2016, heart failure in 2019, treated with surgery, currently diagnosed with acute on chronic systolic and diastolic heart failure, and mild collapsed lung with discharge on medication management. That's a lot. Can you suggest any more precautions I should take to stay safe based on not leaving the house?
Right. Well, you're exactly the patient that's at risk, right? Although you're young, 45. I'm sorry to hear about all your heart troubles you've had, and I want to wish you well. But clearly, with that combination of heart disease and illnesses, you would be at a higher risk of having a more severe infection were you to get it. So I would say that for you, again, those protective steps, self-isolation, masking when outside, avoiding crowds, and standing with other people for long periods of time, diligent hand washing with touching anything, and then doing all you can to stay on your medications and staying fit and healthy with good nutrition and rest would be, I think, the best to do. The biggest risk is going to be, though, that you're going to get coronavirus, is that your underlying heart disease could act up. For instance, your heart failure might get a little out of control if you've changed your routines. So stay on your routines. And if you're having symptoms of the heart, having any symptom, don't delay seeking care, because that's probably a bigger risk to you, quite honest, than actually getting coronavirus. However, I do think that we're going to have to, when we get a vaccine, it's going to be in limited supplies to start out with. To think of all the billions of people in the world who, and this is a worldwide problem, that need to be vaccinated, the time to scale up to make an effective vaccine at that amount is just an immense task. And I would like to say that I think that as vaccine becomes available, the most vulnerable, the highest at risk, the ones who, if infected, we severely impacted, such as folks like yourself with heart disease and heart failure. Hopefully we could find ways to prioritize vaccines into those portions of our population first, just like the elderly in assisted living facilities are a high priority target for vaccination. So stay well, stay safe, follow those steps. This is not going away anytime soon. I suspect this summer we'll have a little lull in the infections and people will let their guard down. And I would say for all of you on this call, stay vigilant, live your life, but live your life safely.
Amy has two questions. She
Great.
wants to know if there's a particular type of mask you would recommend for participants, and also are hospitals in the DC area starting to perform elective procedures? I think you touched on
Right. That's a great question. So we don't have the masks should be, the best kind of mask is just, you can even buy, medical grade masks. And I would buy a medical grade mask. I know they ask for because you want to be able to discard them. My daughter made this very pretty, she was making some masks and just for her own style's sake, and she made this very pretty one out of this material she liked. And that's fine, except it's, it's going to get soiled. And it's a double layer mask. I don't know how permeable it is to virus. So my preference is that when folks ask, that I say try to source some medical grade masks if you can. I don't think you need the N95s. You've heard about those. Those are tightly porous masks that fit really in a tight seal around the face and around the mouth and nose, and provide they don't have, not like a surgical mask where it just prevents, aerosolization. But those surgical masks alone should be fine. So that's what I would recommend. A simple cloth mask of one layer, I worry might be not protective enough. Probably better than nothing, although I don't know. And then last, you asked about procedures. Are we doing elective procedures again? And I would say we've really been doing elective procedures all the time, meaning, and it just depends on how you define elective. To me, elective is, elective, actually, let me unwind that a little bit. To me, we've been doing essential procedures. And so we define essential as time sensitive for the well-being of the patient. And so, yes, if you need a heart transplant, we're going to do that now. Even though it's risky, we're going to find a way to keep you safe. And all of our 11 heart transplant patients, none have had a problem with COVID, even though they've gone through our hospital and been extremely ill, and all have done very well. Same thing. And that's just an extreme example of this. So we've been doing essential procedures. I think elective procedures should be deferred, but by elective, my definition of elective is, I kind of don't like my nose looks. I'd like to kind of get this kind of updated. That to me is elective. Otherwise, there's most of what we do is not elective, because at some point it becomes essential for the well-being of the patient and becomes time sensitive. And everybody has their own definition of that. Some folks are more anxious than others, or feel more pressure on their health with their health problem than others. That should be prioritized. I think that we've almost gone too far in delaying essential care in many respects, as we've seen the numbers drop off of people presenting with heart attacks, for example. We've sent the wrong message that the healthcare system is not safe to come to, when in fact we believe it is safe to come to. that is our job, is to keep people safe first. And, we focus on it quite heavily. But that's come at some expense. I'm going to tell you that, the healthcare team working in the hospital is isolated too while there. Patients don't have their families coming in. How it's been so hard on the patients there, and even harder on the staff, because they're the emotional support for every single patient. So we're anxious to get people back in the hospital, but that's probably a bridge too far right now. So patients come in, deliver essential care, and then they, we kind of quickly move them through, and that seems to be working quite well. But I think we're ready to get back to pretty much all procedures except truly elective. And I don't know. I'm not sure about my nose, but I can wait.
Phil's from his iPad says, is there a role for traditional anti-inflammatories like prednisone in the inflammatory phase of COVID? And do you see COVID CHF in persons with no prior history of heart disease?
Right. Okay, good. So early in the experience in China, there was some use of steroids, but I think it's very controversial. And we are not administering steroids to patients with COVID. When we need an anti-inflammatory, we're using tocilizumab, which is a very targeted, specific anti-inflammatory that targets the principal problem that's causing that inflammatory storm, as opposed to prednisone, which is a general, or steroids that are general immunosuppressants or immune suppressants. So we're not using steroids in this disease state. So that's I think that answers your question. Jeff, was there another part of the question on the end there?
Not that question. Do you see COVID CHF in person? No,
COVID CHF, yes. We are seeing some acute myocarditis. The heart, because of all the inflammation, is suppressed. So a strong heart suddenly becomes weak. And those folks, when we're detecting, we're supporting, thinking that that's temporary. And we've been able to support people through that. There hasn't been as much as that as I thought there would be. I'll be honest with you. I thought we'd see a lot more acute heart failure. We're not seeing as much as I thought we'd see.
Right. Amy has another question. He wants to know, can you comment on issues with COVID rapid testing issues?
Yes. So although I'm not tightly linked into the testing community, our system does provide us a lot of information about that. The rapid tests, I think I'll tell you what, you hear about it, and all these tests, the biggest problem has been the ability to get reagents. The tests, there's been some news lately about there's some inaccuracies in the test, and on the rapid tests, and I personally actually just don't think there's been published data on different tests and how accurate they actually are. So we're using the standard 1 to 2 hour turnaround tests, which is still pretty rapid. I mean, the 5-minute test, 5 minutes, we trust the 1 to 2 hour tests, and we get them done. That's what we're doing. But the problem has been reagents. You've got to have enough testing material to run all the tests. And right now in our system, for example, we have 10 hospitals. We're able to conduct 50, and tons of clinics, we're able to conduct about 5,600 tests a week with the reagents. And that might sound like a lot, but it actually is just barely enough. It's just barely enough to test folks, because our test positivity rate is running around 15 to 20%. So 8 out of 10 people we test are negative. When someone's in the hospital, we occasionally have to test a couple of times because we want to make sure we don't have false negatives, particularly when the patient's problem looks like COVID. We will test again, and occasionally we find a positive, but most times not. So rapid is a matter of how you define it, but our rapid tests are 1 to 2 hours, which we find sufficient and time sensitive. There are more rapid tests, but I think, again, those are very limited in availability right now, and the reagents is the key thing.
Let me combine a couple questions because I think they're simple answers. Michael Kalinsky says, will it be necessary for high-risk patients to maintain social distancing until vaccines available? there's a question about wearing gloves outside or in stores. You might comment in general.
Yep.
I think you could
Yep.
do both of those together.
Look, team, I think social distancing is a thing is here to stay for a while. There's this virus, because it is not the flu. It is, you find evidence of active viral shedding for weeks after infection, and in all sorts of ways, shapes, and forms, and so, and as long as folks can have asymptomatic infection in the community, which they can, it's very difficult to know who is and who is not infected. And so I think social distancing, until there's a vaccine, is going to be something that we all keep in mind, and practice. You see people defying this, but to me, it defies logic at the moment. I know there's been economic wreckage from this, and I follow that very closely. And there's been economic wreckage even for hospitals, because people stay away and we just focus on COVID primarily. But I think for now, social distancing is going to be key, because we don't have, as I've reviewed for you, the treatments are not a panacea. They're only treatments for the most sick of the sick. They're all intravenous drugs when people are really and they're limited in they're not complete in their efficacy. So until a vaccine's available, I think this is the way we're going to approach it. Gloves to me are they're a little bit of a double-edged sword, because while you have a glove on, you feel like you can touch anything, and then you can forget and you touch your mask or you touch your face, and you still have to wash your hands before and after putting the gloves on. That's something people often forget. Just because you're putting a glove on, it's not the same as washing your hands. So you wash your hands before you put the glove on, and you wash your hands when you take the glove off. That's the hospital protocol. In the hospital, even if we put gloves on, we go into a patient's room and we have to wear gloves to do something, hand washing before and after. So I think as long as you're washing your hands and not doing what I just did, touch my nose, you're fine. But if you touch your newspaper and then you're all over your face, that's a problem. So I think it's your hands are just a way to get virus from one thing to another, and again, it's your face where the risk is.
John Martin wants to know risk of swimming pools. What do you feel about everyone being tested? I mean,
Risk of swimming pools?
Yes, those are two, right? Risk of swimming pools, right?
No, yeah, I don't know. I think there's a lot of social congregation, and then there are the wet areas of swimming pools, bathrooms, and so forth, which to me seem. So I don't know what community pools are going to do this summer. I think there's probably safe ways to open, to spread chairs out and turn and close off the wet areas and the snack bars and stuff. But I think they're going to have to practice good discipline. And it's, lots of kids running around, and they have a hard time staying away from one another. And, it's just a tough, I think that's a real tough one. I'm interested to see, but I think it could be done if it's more about congregating crowds than it is about the pool itself, and the water. I think the water, I don't think the water itself should pose an issue because of the chemicals in the water. I don't know that for a fact, though. I'm just surmising. Great.
Okay, before we do leave, and I want you to stay through the end of this, it won't be long. I'd like to ask a question someone else has asked and brought it to my attention. I am a volunteer in many areas. One of them is in the hospital. Although it's not for Medstar. Oh, actually it is now, Shady Grove. No, it's not. It's at Medstar. Please forgive me, I'm not a doctor. When do you think Medstar would allow volunteers to come back in, or do you know anything about that?
Yeah.
Probably don't.
Well, let me thank you for volunteering, and I know we need our volunteers. We don't want to pose risk to them, though, and some of it's about limited PPE, and we just have to limit the number of people that are coming into the hospital because they all need PPE, and they only have so much to supply. So it's a complicated answer. It's about when is it safe to have additional folks coming in and out? When do we not want to pose the risk to them simply being in an environment where there's quite a bit of COVID? For example, in our 700-bed hospital right now, this morning, we have 160 COVID patients. Many of them in the ICUs and on the floors. And so, but I know we need our volunteers, and we appreciate them very greatly. And even my daughter's a college junior. She interested in medicine, and she had applied to Georgetown to be a volunteer on the children's unit this summer. She has an interview this week for it, but we have no idea if they're going to open up that program. And I haven't heard anything, actually, and I'll just give you my own intelligence. Haven't heard anything about our volunteer programs opening. I haven't heard that they're not going to, but I haven't heard about them opening. I think the hospitals are still sort of, at least the ones like ours that are really involved with COVID, are still just responding to the crisis while they try to deliver essential care. But you can know that we value our volunteers, and the earliest we can get them back where it's safe, I know it's a priority for us. And again, thank you for volunteering.
Guys, my dog pushed her way in. I got one or two more questions now that came in too. You answered the volunteers. Any data, Jay Roberts says, any data on percentage of total COVID infected population that progresses to phase 3? I mean, it's just severe, I don't know what it means.
Yes, right. It's the minority. It's the minority. Of folks that get admitted, it's about 15% that wind up in an ICU. And of those in an ICU, that it's a fraction of those that go on to have, it's about an overall 5% death rate. And it's that 5% that really has that extreme reaction. It depends on how you define it, because I'll tell you, we find the inflammatory reaction to this virus is something just we just haven't even seen before. We're getting levels of, we measure these levels of inflammatory markers, and we see levels that we just haven't seen with other diseases. It is intense. And so we look for the folks with these hyperinflammatory responses, and then we're becoming very quick to use convalescent serum and then tocilizumab to knock that down, because if the body can fight off the infection, usually, if we can support the lung function long enough. But if the body goes haywire because of the immune reaction, you can't turn that off. That's the body attacking the body. And at that point, you're really losing. So it's really we really look for that, and we become very proactive about treating this hyperinflammatory phase.
Okay, the last question, then I think we'll thank you and close off our session, is from Spansosa 1. Now that we're entering the mosquito season, is there any evidence that COVID-19 transmission through that vehicle with the mosquitoes? Is the question. Yeah,
gosh, this is when I wish I had my good friend, my infectious disease expert, Glenn Wertman, right in my hip. I haven't heard about that yet. I haven't heard anything about that. It's a really good question. And let me just do this. Rather than babble and get it wrong, let me ask Glenn, and I'll get the answer to Norm and to Jeff, and they can get it out to the group, because I know they'll probably be sending out after action communications, thanking you all for your generous time and listening today. And I can make sure that's included. If I can learn anything functional about that, I will definitely find out for you.
Hello, my name is Ash Ramamurthy, President of Medstar, Chapter 94, the National Capital Chapter serving Maryland and DC. Welcome to our support group for those dealing with heart diseases as well as their families and caregivers. Each year, our chapter's accredited visitors provide support and shoulder to lean on for heart patients and caregivers at 6 area hospitals: Medstar Washington Hospital Center, George Washington University Hospital, Adventist Healthcare White Oak and Shady Grove Medical Centers, Suburban Hospital, and St. Agnes Hospital in Baltimore. Our mission is as important as ever and will remain strong thanks to online technologies such as Zoom. I would like to personally thank all of you who are watching this video today and encourage you to join Mender Hearts. If you are not already a member, go to website menderhearts.org, click join in the upper right hand corner. Our chapter's vice president, Amy Dukovic, will now say a few words. Thank you very much.
Hello, I am Amy Dukovic, Vice President of Mended Hearts Chapter 94. Our chapter has held support groups monthly for nearly 45 years. But with the onset of COVID-19, we are now holding these meetings using Zoom online technology. We hope you find this format helpful in keeping connected. We are recording and archiving clinical presentations in case you are unable to participate in our monthly meetings. We are placing links to these presentations on our chapter website, and that is www.mendedhearts-metrodc.org, so that you can access them at your convenience. To echo my colleague Ash, on behalf of all of the officers and members of Mended Hearts Chapter 94, we thank you for your interest in our organization and wish you all good health.